with a drug-eluting stent. This is the data from Rotterdam, where you can see that the patient who came in for a STEMI procedure and had a sirolimus-eluting stent implantation with a large thrombus burden had significantly worse outcome in comparison those to patients who had a very small. There are many reasons for that. I won't go into a great detail of it in the interest of time. But now, as I want to talk about the evolution of the PCI procedures, now I will talk about some of the newer solutions that we have in trying to improve these procedures. So the most important thing that we need to do is to somehow manage the thrombus in such a way that we minimize the bleeding, but we address the thrombus at the maximum level. So there are multiple devices to address thrombus. There are mechanical aspiration devices, mechanical thrombectomy devices, as well as distal embolic protection devices. But who knows what's better? There's a whole bunch of these devices out there. So at European Society of Cardiology, this trial was presented. This is a meta-analysis of close to 3,000 patients, which took almost all good thrombectomy trials, which are in the literature, and looked at them and provided a one-year follow-up. So in brief, all the mechanical thrombectomy devices, which is very complicated devices like rheolytic thrombectomy, rotor-Rex catheter, there's a whole bunch of these devices out there. But they were no better than a standard PCI. However, a simple manual aspiration catheter, which Dr. Parikh actually is a pioneer in that area. He actually was involved in the initial trials of the aspiration catheter right here in Ahmedabad, showed a cumulative survival benefit in the patients with primary PCI. Now, when you did the manual aspiration and added glycoprotein 2B3 inhibitor to that, the mortality was even the lowest. However, there are limitations of these thrombectomy devices too. The New England Journal of Medicine article from last year was called TAPIS trial, which is a 1,000-patient aspiration thrombectomy trial. There were only average 50% of patients who actually benefited or had successful aspiration thrombectomy when they use an aspiration catheter. So there are limitations of aspiration devices. So how do we get around it? So there are a couple of ways to get around it. In Europe has been ahead in this area than the United States. Jochen Worley from Germany had several years back had promoted a concept of intracoronary F6-mab infusions. So this is a retrospective analysis of 400 patients, and you can see this is a IV F6-mab versus IC F6-mab, which is giving F6-mab glycoprotein 2B3 inhibitor right into the coronary artery, and there was an improvement in the death and MACE events with IC F6-mab. This was a randomized trial. This is another trial from Germany, which shows that the infarct size was much lower in the patients those who had IC. There are many benefits of IC F6-mab. Now, I know I'm short of time, but I will show you very briefly a case before I conclude. One of the ways to dethrombectomize the vessel, which is very popular in US now, and there are multiple studies which are ongoing, is by using a special PTFE balloon that perfuses F6-mab in the coronary artery. It contains the thrombus and it injects the F6-mab inside the thrombus and allows very high concentration of F6-mab, which almost acts like a thrombolytic therapy without having the bleeding complication. So what is the most recent this is an OCT image of an LAD where you can see this is a large thrombus burden inside the LAD. This is the thrombus, this is LAD, and this is after using that PTFE balloon called Clearway catheter and delivering localized F6-mab. You can see that the thrombus burden is now significantly reduced. It also sometimes facilitates the thrombus removal by aspiration catheter. So we quite frequently use this catheter, deliver the F6-mab intracoronary, and then use manual aspiration in addition. This is a Crystal AMI trial, which is a single center trial. At my center right now, we have done 40 patients in this particular study. We have in fact done 700 patients with perfusion balloon now. But you can see this is a randomization between IV F6-mab and F6-mab delivered via the Clearway therapeutic perfusion catheter, and then measuring the PCI success parameters, and then 30-day follow-up. Here are the results. You can see that the tissue level perfusion and TIMI flow is very, very high in the intracoronary F6-mab arm, and it was also very good. However, not as good as I see in the IV F6-mab arm. 65% of these patients had manual aspiration thrombectomy catheter. This is the internist's wife in town, and this is a 38-year-old lady that came to the emergency room with a VF arrest. She arrested in the ER. She had an anterior MI. She was revived in the emergency room, taken to the cath lab. You can clearly see what the problem is. She has very tachycardic from resuscitation. She has a proximal LAD occlusion. Here's a great example of what happened in the TAPAS trial, that not everybody benefited from aspiration catheter. Here's a wire into the LAD and an aspiration catheter was used. In fact, aspiration catheter caused embolization of these thrombus into the left coronary system. And the patient had a global no reflow, had second VF arrest. At that time, the clear with hepatic infusion catheter was placed. You can see intracoronary glycoprotein TB3 inhibitor immediately restored the flow into the LAD and myocardial grade perfusion. This is after drug-eluting stent. The LAD flow is completely restored. This is 30-day follow-up in this patient. She went home 2 days later, but you can see on a resting systemic scan there is no infarct. So, in summary, we have come full circle. There are many other modalities in investigation: supersaturated oxygen delivery, cooling, stem cells, proximal protection, and another multi-center trial ongoing evaluating the effects of intra-aortic balloon pump. But none of these modalities have any evidence which favors use of these treatment therapies right now. So we have come full circle. Managing the thrombus during a PCI procedure in a STEMI patient is everything. This can be done with aspiration manual thrombectomy catheters. I am short of time, so I won't show you a great detail about the oral antiplatelet therapy. There is a lecture here on that, which is a very important lecture. There was a Triton TIMI 38 trial, which was mentioned earlier, which is a randomization of ACS patients between clopidogrel and prasugrel. Prasugrel showed significant benefit in comparison to clopidogrel in a STEMI subset. Also, use of vasodilators routinely during a STEMI PCI procedures. Injecting sodium nitroprusside in the coronary artery is also found to be very beneficial. And localized at 6 mm delivery by a clear wave therapeutic infusion catheter has a great promise. There is a new multi-center randomized trial which we just started 2 months ago called Infuse AMI, which is going to examine these concepts. So, to conclude, our understanding has evolved significantly, that what actually happens to these patients, how we improve myocardial tissue level perfusion, how we reduce the infarct size, how we quickly achieve TIMI flow. Our processes have evolved and our therapies are evolving. Combining mechanical thrombectomy, such as with an aspiration catheter, with a good aggressive antiplatelet pharmacotherapy in the cath lab has shown benefit, continues to show benefit, and will remain a standard of care in PCI. Improving oral pharmacology, which I mentioned, prasugrel rather than clopidogrel in select patients, especially diabetics, will improve outcome further. And one thing that I did not show in a trial fashion is the use of drug-eluting stents, but in Horizon AMI trial, the Texas stent, there was no mortality difference between a drug-eluting stent and a non-drug-eluting stent. And in fact, what was shown was that the drug-eluting stent TLR rate was significantly lower than a bare metal, which is what we would expect. So I hope this gives you a kind of a glimpse into a life of an interventional cardiologist once you make the commitment of taking the STEMI patient to the cath lab, and it was helpful to you. Thank you very much.